morning, everybody. I'm happy that the room is filling up slowly but surely. I welcome you, everybody, to our first session of today, which will be dealing with obesity stigma. I think obesity stigma is probably one of the greatest, if not the greatest barrier that we all can face in obesity care. There's different perspectives, and we will try to look at all of them today. The society perspective, the healthcare provider perspective, the patient perspective, and also the surgical, perspective. And the idea is to learn more about where does it come from, and maybe even better how we can change the narrative to improve care for all patients living with obesity, and finally turn the field towards evidence-based medicine. So it's my great pleasure to chair this session together with Lilian Kao and Ada Casajoana, and I hand over the word to you guys.
Well, good morning, everyone. It is my pleasure to introduce you to the first topic, which is obesity in the public eye, stigma in society and media. And it's my pleasure to introduce my co-chair, who is Dr. Ana Casajoana, who comes from Barcelona, is a researcher within the Cardiovascular Risk and Nutrition Research Group. Dr. Casajoana, at an international level, serves at the IFSO-EC Communication Chair, and nationally, she's the member of the Executive Board of the Young IFSO Spain section. Welcome.
Okay, good morning, everybody. So, as they introduce me, I will introduce you in a stigma topic, and I will talk about the stigma in society, in scientific societies, and in media also. So, I have nothing to disclose. So, the word stigma is not an abstract concept. The stigma comes from the ancient Greek, and a stigma at the beginning means a mark on the signs in the body. And these marks represent something different with a negative label, and usually the slave and criminals and traitors has these marks with one purpose: to identify, to shame, and to exclude these people. So nowadays, stigma is not a physical mark, it's a mark on a person, it's a social label. And this reduces the person to a negative concept, to a negative point of view with the same purpose like in the beginning. So nowadays we have multiple definitions studied by philosophers, sociologists, and contemporary sociologists as Erving Goffman developed different theories about the stigma, and he has 2 books that if you have interest, I think it's a must to read. The first is The Presentation of Self in Everyday Life. And with this book, Goffman wants to describe the social life as a performance, and where people manage impressions using a front stage and backstage. And the second book is The Stigma, and the stigma is analyzed as all the person's feelings about himself and his relationship to the people whom society calls normal. So for him, and I think this is an accepted description about the stigma nowadays, the stigma is when a person is judged because of one characteristic and feel different types of stigma, intrastigma, stigma for the others, and the stigma is everywhere, as we will see during this session. So there are different types of stigma based on physical, how people look you, character, how people feel you when see you, and tribal aspects, that it's not depending just in physical and characters because it's a part of a group that you are or grow. So with all these concepts I introduced, you could see that probably obesity has multiple stigmas around the disease, and probably with the high rate prevalence and high rate of multiple stigmas in the same concept, obesity stigma probably will be huge in our society. And yes, if we see the prevalence in our environment, the stigma in people with obesity, it's around 1942% of these people report experiencing weight discrimination sometimes, And if you look just several obesity patients, so the stigma is up to 60%. So, and if you see the perception of the stigma in general population, more than 20% and 40% of these people reports sometimes experience a weight stigma. And the weight stigma is not just in the people who live with obesity. The stigma is in the healthcare professionals, and a stigma is not just when the person has obesity. It's there too when these people lose weight, so the stigma continues after this. Today, the organization continue working to better define, as our philosophers or sociologists, and reduce the stigma. And the different scientific communities organize different guidelines like this from the Canada group that give you the different approach to how to treat these patients in the outpatient to treat the problem. And in Spain, we adapt the same guidelines, and with the guidelines hero to approach the stigma in our practitioner. So there are a lot of slogans and campaigns like this from the Obesity Canada that wants to see more science and less stigma in all our work. And I think here the topic increased during the last 10 years, as in this graphic that you can find in the PubMed. And I think here there are two game changers in the scientific community. The first is this. This is the joint consensus of 2020, led by Professor Rubino, where 36 experts evaluate 11 domains and develop a Delphi consensus to be agreed or not agreed about the stigma definitions and stigma situations, and most of the scientific communities accept and support this. So I think this is the first. And the second, and I think most important, is the different point of view about how to define, how to diagnose, how to treat clinical obesity, led by Professor Rubino also. And I think what is important about this is that it changed the point how we think, how we treat the obesity, and we start to focus on clinical impact, not just in BMI. So we recognize obesity as a complex disease, and it changed the way how we think, and this thing changed our language, as Paulina explained yesterday. So we changed concepts like weight-based to health-based, from labeling to clinical evaluation, from blame to disease understanding, and it changed concepts like weight regain to weight recurrence, reflecting the chronic nature of the disease. But be realistic. Scientific data is so important to give us concepts, but the media powerful probably is one of the most important tools for the general population. And if you think in the Erving Goffman concepts and see the evidence in different systematics reviews that we find about how media could impact in the obesity patients with obesity, we have this dual role. So we have the positive role of media, where you could find that media connects people that feel the same as stigma, and not just people with a stigma. It connects people who are wise, like Erving Goffman said, the wise people who feel empathy for a person who lives with a stigma without live with a stigma. So these people help the others to live with a stigma. And I think what is important too in media is this metaverse environment where people who live with a stigma could be another person different, because in case of weight stigma, it is a reversible stigma different than a congenital stigma or others. So these people can feel like what is normal because they feel different from the normal society. So they can feel this digital identity, this avatar identity beyond physical appearance, with less judgment and more belonging. But of course, the media could have a negative message. So creating a stereotype, blames, memes, ridiculizing, and of course giving misinformation about obesity and the way how these people need to ask for help, for example. And a person who lives with a stigma could be a victim because they want to change what is not normal for them. So in this type of a stigma, it's so important not to see that these people has a victimization around them, and that people could see an opportunity, for them to gain something. So if we continue looking for the media evidence, we could see what was important in media is the images. So the weight of the images, to give a positive or negative. So here in this table, you could see, in red, images that increase the stigma, or images that respectful and decrease the stigma. So an example, just to show you, which type of images are positive or negative. So images like body focus pictures, like the one, instead of show whole person living naturally with obesity, or the image always, when we think in obesity, to think in unhealthy food. Okay, this is just one piece of all the standing disease. And maybe it's better if we show people who live with obesity in neutral situation, not always eating unhealthy. And of course, another pictures like the third, where people have no face, and is anonymous people showing just a part of, again, of the body, instead of humanized images with facing expression like smiling, or other images like passive behaviors instead of daily life activities, or maybe sad images instead of social inclusion and support. And of course, a lot of videos and a lot of scenes that stereotypes and ridiculize these people instead of respectful. So if I show this image, this is a campaign from States about not to treat childhood obesity. So you could see that probably this image impacts you, Maybe you could think there is a good campaign to prevent obesity, and probably it reminds you the cigarette campaigns. So here, if you read the first sentence, the campaign saying fat prevention begins at home, and the buffet line. The second picture with the girl said, it's hard to be a little girl if you are not. And the third, my fat may be funny to you, but it's killing me. So maybe for you it's a good campaign, but if you analyze the message of the picture and the text, the first blame families and personal responsibility while ignoring biological and social factors. The second one promotes body shame and negative self-image, especially in children, saying that if you have obesity and you are a girl, you are not cute. This is a message probably that you can learn there. And the third, of course, use fear and emotional guilt, which may increase the anxiety and internalize stigma. So we know that this type of campaign, like cigarettes campaign, it's not working in obesity. So because of that, a lot of scientists, communities, and federations organize a different bank images that I encourage you to use it. So one is the World Obesity, that you could find different pictures of people living with obesity in different situations, different countries. This is another bank images that you could use it in your routine days. And of course, media could transform, it could decrease. We can work with media to decrease the stigma with education, with accurate information. So as Marcos said, we can change the narrative of the stigma. So as this level about the stigma said, reduce weight stigma as part of obesity is our goal as a professionals. So I will not conclude because I think in all the presentation will be a lot of message. But of course, the stigma is deeply, deeply rooted in society. The stigma has a real consequences, and here the social media plays a dual role to enforce and also to reduce. And we need to use all the tools to fight the stigma in obesity people. and of course in another environments like healthcare environments. So thank you very much for the presentation. So,
Thank you, Anna.
Okay.
Any questions from the floor? May I start with Anna? With media, as you know, journalism, media looks towards sensationalization and quite often, posting images that might be stigmatizing, but it actually attracts attention. How do we try, for us as a healthcare professional, to educate journalists not to do the mistakes that we don't want them to do?
yeah, I think this type of sessions like we are organizing here are so important because we need to educate our friends, our families, our environment in the hospital, because I think for a lot of years, the stigma was just treated in integrated health tables, medical tables, and I think that we need to understand as a surgeons and as a professionals that treat obesity with bariatric surgery, to include the stigma in the outpatient at the beginning and through all the process, and of course after, because after start another stigma related with bariatric surgery and weight loss.
And I think patients feel it too, because how often have we heard our patients say, I'm going to have bariatric surgery, but my friends say I'm taking the easy way out.
Yeah.
So again, it's about education. It's about treatment, not taking the easy way out.
Yeah.
Anybody has any comments or questions to Anna? If not, I think that was a great introduction to this session.
This time.
Thank you very much.
So now Alex Miras will continue the session. So I think Alex doesn't need a presentation. He is from UK, and he will talk about, about the weight bias in healthcare system beyond primary care, and we are part of the problem, as Lillian said. We'll see.
Great. You'll be pleased to hear that I have no slides, so it is some thoughts, reflections.
I can tell you I received like 5 WhatsApp messages. He hasn't uploaded his slides. He hasn't uploaded his slides.
That's right. So thank you very much for the invitation. I am an endocrinologist in the UK and a practicing obesity physician. I'm going to start by saying, and being positive here, that I think we've come a long way. Even though there are many, many things that we can do, we really need to be positive about the things that we have achieved. There are many proofs, pieces of proof that what we have done is good. If we went to meetings, if you went to your general surgical meetings, not the bariatric ones, the general surgical meetings about 15 years ago, you would be thrown stones, yes? Because of the specialty that you were representing. When I would go to endocrinology meetings around the world and talk about obesity and bariatric surgery back then, 15 years ago, I would also be thrown stones, yeah? But now what's happening is that we do go to our general colleagues meetings and we don't feel ashamed for what we are doing, for what we are representing, and people are listening a lot more to what we have to say. So that's really good news. Even in the UK, which is one of the most stigmatizing countries around the world, the narrative is actually slowly changing, even within the media, which again is one of the most stigmatizing media around the world. So we are doing much better. We are doing pretty well. Now, I don't know if the title of the talk is suggesting that primary care colleagues are more likely to stigmatize than secondary care or other colleagues, but I don't think that there is necessarily any evidence for that. Just because we in this room perhaps are specialists, and most of us, not all of us, are based in secondary care, this doesn't mean that we stigmatize less, and it doesn't necessarily mean that we know more about obesity either. Therefore, I'm saying that because personal experience, would be interested to hear your thoughts, but personal experience from other colleagues in secondary care, even very prominent professors that I have worked with over the years are very, very deeply stigmatizing against the condition. They don't seem to appreciate the nuances, the biology, et cetera, et cetera. So I don't necessarily think that there is a big divide in terms of the prevalence or strength of obesity stigma between primary and secondary care. When we are trying to combat stigma, I think that it is important not to necessarily confront people. I have done that, and I don't think it works particularly well. I think because there is a danger that if we confront people and we shout at them once, twice, or 3 times that obesity is a disease, we are in danger of alienating them. And we cannot blame neither our primary care colleagues or our secondary care colleagues, or indeed many other healthcare professionals, for not knowing enough about obesity, because I think none of us in this room were taught about the principles about body weight regulation and the principles underpinning the development of obesity in medical school or nursing school or dietetic physiotherapy school, etc. So I think we need to be a little bit more gentle in the way that we approach our colleagues and we discuss this. As I alluded earlier on, shouting that obesity is a disease until we go blue in the face is not particularly helpful either, unless we have got good justification as to how to explain this. Because if someone, and we need to also respect our colleagues' intelligence, right? So if an intelligent colleague of ours asks us, okay, so tell me why you are shouting obesity is a disease, we need to have a pretty compelling story as to how to answer to that comment. And I don't think that we necessarily all do have this compelling story to tell. I'm not saying it is an easy story, by no doubt. We know still very little, but we know a lot more than what we did some years ago. So explaining the biology and the biological underpinnings and the environmental underpinnings towards body weight regulation in a clear language that can be understood well by our colleagues is the key to changing their views. Because if someone understands what we are telling them, then they are much more likely to reflect, think about this, and change their point of view. Let me just also perhaps challenge some of the things that we're doing, but I'm doing this purely to make us move a little bit further forward. Language, of course, matters. But again, trying to tell people that, instead of calling people obese, we should be saying people living with obesity is the right thing to do. It's a start, but again, it's not enough. We need to make people understand why we are saying what we are saying. Telling them that obesity is complex is not helpful either. Because just because something is complex doesn't make it a disease, yeah? So we need to explain what the complexities are, what we do know, be comfortable with what we know, and be open also with the many, many things that we do not know. I will now move on to, apart from this brief introduction as to how we can perhaps try to convince others about the story and the narrative, again, based on very solid scientific evidence with the appropriate degree of understanding, etc. I would like now to move to some of the things that even we do on a daily basis, the things that we say on a daily basis, and I have experienced this in a number of healthcare settings in my own career over years, in some pretty well-known medical centers that treat obesity. So it's about challenging the way that we talk and we deal with some aspects of obesity care. Because now what we are seeing is that the worst part of obesity stigma tends to be improving everywhere. We are removing a number of the terrible things that were said in the past, but now we are seeing more subtle forms of obesity stigma that are a little bit more nuanced, and we need to root them out, tease them out, challenge them before they change. So again, perhaps along the same lines as to what Lillian commented on just a moment ago, which is to say that either medications or bariatric surgery are tools to losing weight or improving health. Using the word tools means that the person still has to do hard work. Otherwise, these tools are not going to work. And this is something that we really have to move away from. Now, as endocrinologists, are doing exactly the same with medications, yes? So we are now saying to people, tirzepatide and semaglutide are tools for you to lose weight. If you do not change your eating behavior, this treatment will not be successful. And let's just, try to dispel all of that and say that the reason why both bariatric surgery and pharmacotherapy specifically, I'm talking about those specific treatments, work, is because they are biological treatments for the biological component, and there are more components, there are biological treatments for the biological component of this complex condition. The reason why these treatments work is because they change eating behavior. Yes? It's not that it is treatment plus change of eating behavior causes the outcome. These treatments work because they change eating behavior, and that is what causes the outcome. If those treatments are not successful, if we were to use the word success, it's because they don't change eating behavior, and that's why we're not seeing the health benefits of the intervention. Now, this doesn't mean that we do not involve in the care that we are delivering people from other specialties with a view to making this treatment more successful, more healthy. So the way that I would flip this challenge that medications or surgery do not work without people making changes, I would say that the treatments are going to work whatever the person does if the treatment is meant to work. But if in addition to that we make changes to someone's sleep or stress or social environment, blah, 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 then we're going to make the treatment even better and even more healthy for the individual. The same applies, and that comes up a lot of the time, when treatments, again, following on from what I've said, when treatments don't work. Now there, we start feeling uncomfortable, yeah? You give someone a gastric bypass, you give someone tirzepatide, they come back to you, and they haven't lost any weight. Now, it is very humane for us to feel uncomfortable when that happens, yes? And unfortunately, over the years, when doctors or healthcare professionals feel uncomfortable, they tend to go back to basic principles, which are to blame the patient. And this happens very often with, obviously, in obesity. So when someone comes to you and they have not responded after treatment, and that applies for me when they come back after pharmacotherapy and they have not responded to treatment, as unlikely and uncommon as this is, we just need to accept it, be comfortable with it, understand what are the things that perhaps could be changed around someone's life. But if not many things can be changed, we'll just move on to the next biological treatment in the same way that many of us in the room, including Dimitris, who is at the back, when we're using oncological treatments, we just go on about what the patient's life is. We just say the treatment doesn't work, let's move on to the next one. A couple of thoughts, and then I'll finish and say that the weight plateau that people reach, and again, I'm biased now towards medications. Will people reach their weight plateau? Let me tell you another form of, I suppose, misunderstanding of the nature of obesity that even we do not always appreciate that we do. So someone is on semaglutide, tirzepatide, they reach their weight plateau, and then they say to you, but doctor, I want to lose a little bit more, right? The temptation is that for us to say, well, if you try a little bit harder, you will lose even a little bit more. And again, this is something that is very unlikely to happen. We might be exacerbating yo-yo dieting. Yo-yo dieting that the person did before they were on treatment, now we're doing it when they have reached their plateau. And we're saying, if you try even more aggressive type of treatments, you will lose more weight. The answer is no. They will start yo-yoing around their new plateau. Again, in the medical field, talking about stopping treatment. Again, I think stopping treatment is, in a subtle way, part of stigmatization or perhaps not understanding the nature of the disease. So saying to people that we're going to stop your semaglutide or tirzepatide or whatever it is that you are taking, and then you just need to try hard to maintain the health benefits is silly. Yeah, these are, again, biological treatments for the biological component of the disease. Finally, I'll give you a recent example which I have experienced. I will present that to you perhaps in the future. We are currently developing a checklist of healthcare essentials. So basically ways to assess people with obesity, assess them in terms of their medical complications, their physical complications, their mental health complications. And I was very surprised that when I shared this with colleagues around the UK coming from different specialties like dietetics or psychology, etc., I was criticized for over-medicalizing obesity. Right. So we go around the world shouting that obesity is a disease, but we don't want to medicalize it. I mean, this is a paradox in terms, right? I think we should be medicalizing obesity because any disease that we have treated successfully in medicine, we have done so by medicalizing. Now, this doesn't mean that we forget about the sociological aspects or the psychological aspects, but medicalizing obesity is the right thing to do. And we should not be shying away from that either. That's about it. These are some thoughts. And again, thanks for the invitation. And we'll be keen to hear what people have to comment or ask. Thank you.
Well, thank you very much, Alex. Great as always and as expected. Thank you. Are there questions from the audience? There's one question.
And before Jimena talks, it's important to say that, if there are some things that I have said that you disagree with or are challenging some of your preconceptions, it's fine to have a debate. You come up and we have a good discussion.
Yeah. And I agree with everything, Alex.
Do you mind to quickly introduce yourself?
Yes, my name is Jimena Ramos-Salas from the University of Lund in Sweden. And I have a question for you about the whole idea of stopping to say that we need the treatments plus behavior and lifestyle interventions for these treatments to be accepted and to work. Is there, do you think, a need to explain to people that behaviors are also biologically driven?
Exactly.
Because people think that behaviors are all about willpower.
Exactly. So I often hear the word choice. Yeah. And I've now got a new way of trying to deal with that. Again, I have failed many times to explain that. I'm gradually, hopefully, getting better. And I'm saying, how much choice does someone who has been in the desert have when it comes to them seeing a well of water and choosing to drink from that well, right? So people cannot think themselves less thirsty, right? In the same way, people cannot think of themselves less hungry, if that is one of their symptoms, right? So I'm therefore trying to explain to people that these are not, eating when you're feeling hungry is not a choice, right? So, and again, it goes back to trying to explain to people exactly that many behaviors, not all, but a very substantial amount of behaviors are driven by biology. Now listen, we don't need to go into which parts of the brain do that and so on. People don't want to hear that, and unless we have a really good knowledge of what we're saying, we also need to be careful. But we just need to put those concepts across and be ready to answer difficult questions.
One more question.
Thank you.
quick
My
and
name is Eva
concise.
Conceição. I'm a Portuguese psychologist from University of Porto. It was lovely to hear you. Thank you. I'd like to comment on two things. I loved your talk. Thank you. But I also loved this last question that Jimena posed, because behaviors are indeed not just psychological. Compulsive eating, hunger, and loss of control eating are highly modulated by internal factors and biophysiological neurometabolic factors, actually, and for brain function, as you were saying. So no, behaviors are not just psychological. It's not just a question of willpower, and research highly supports this, which areas in the brain are actually involved in different eating behaviors. So thank you for this and for highlighting this idea, which is very important. The one thing that was not, this is like a question that I will pose you. It's just to generate the debate. One of the things that you said is that about terminating treatment. And that's not, that a lot of people say that sometimes patients will not go on treatment and they just have to need to have willpower. I would like just to highlight, excuse me, I would like to highlight that treatment is just not surgical and pharmacological. We have psychological interventions that, although they do not have a high weight loss, has other interventions that are also useful, and it's very powerful when you use in combination with other therapies. And when I say in combination, it's not just together. We can use it together with other interventions, but we can use it when the patient is not in a position to do medical treatment or when surgery is not working anymore. So you can use in between
Excuse me, for time reasons,
Okay.
you know,
So
do you want to respond anything,
no.
Alex?
Number one, a number of psychological interventions have a biological basis for
Yeah,
obesity,
absolutely.
right?
Yeah.
So it might be seen as a psychological intervention, but it actually works by changing biology. That's
has to,
one
yeah.
comment, right? The second comment is very specific about medications, because we cannot stop surgery. I think the mistake is telling people that we're not going to stop your semaglutide and we're going to use a psychological therapy instead to maintain your weight loss. And we cannot do that. As you say, we can do it together, right? We can continue with the psychological therapy and so on, but we cannot use it instead, because then we're going to lose the effect that semaglutide or tirzepatide have.
Well, I think we need randomized controlled trials. I do believe we can do it instead.
No.
Not forever, but for
We can't.
Well,
We can't.
All right,
I will wait for the randomized
We
controlled
cannot stop.
trials.
In the same way that we cannot stop bariatric surgery, we cannot undo the gastric bypass and expect people to maintain that
Yeah,
weight.
yeah.
I think the same principle applies. We can talk
Yeah,
offline.
absolutely.
All right.
Thank you.
Thank you very much.
as you see how controversial this topic is, and I really like the discussion, but we have to move on in the program. Thank you very much, Alex. So the next presentation is highlighting the patient perspective, and I don't know whether the next speaker is here. There she is. So we talked a lot about the stigma, how it is being externalized, but obviously it's also some internalizing aspect of it. And we are very much looking forward to the silent struggle, the internalized stigma among people living with obesity, the perspective from Vicky Mooney. Thank you very much for coming and for sharing your thoughts with us.
Thank you very much for having me this morning. Good morning, everybody. Do you know, as a patient, it's always very interesting sitting here listening to opinions and debates, to the comments. Now, first of all, I would like to say, Alex stole my line. I don't have slides either. So you're getting off really lightly this morning, so enjoy. But secondly, as a patient who has sat in this area for the last 15 years, and as a mother who is 49 years old, who has obesity, who has MAFLD, who has depression and anxiety, who has 3 children, is a single parent, and has gone through what life is like from childhood with obesity. I have learned so much from all of you over the last 15 years that I'm just grateful that I get the opportunity to stand here and give back with my experience. So thank you for actually coming down so early in the morning and being here. So realistically, my role in the obesity space is as Executive Director of European Coalition for People Living with Obesity. We are a patient organisation in Europe of patients, of people that you know, loved ones that you know. It could be a father or a son, it could be an aunt, it could be a colleague, it could be somebody sat right next to you who is a patient living with obesity. And I took a few notes because I generally just don't like slides when you're trying to communicate your own experience, but I'd like to share on the challenges I faced when it comes to obesity stigma. And that exists in healthcare, which we know, which is why we're all here, right? But it exists in our own families. It is prominent in our own families. As we know, and we've heard and seen, it exists in the media. And the media generally don't like me. Some surgeons generally don't like me because essentially I like to tell it as it is. You can have all the data in the world, but my lived experience and that of millions of people around the world cannot be disregarded. So the media generally don't like when I come knocking. It exists in schools. Unfortunately, it starts at such a young age. And I think as parents, we have a responsibility to make sure that that isn't happening with our own children. It exists in systems. And when I say systems, I go in and out of the European Commission and Parliament, and I challenge every single time I can the policies that are in place because they are rooted in stigma and obesity stigma. At the very framework of a lot of healthcare policies is obesity stigma. And I look at MEPs and I say, how are you going to change things if you yourself have implicit bias? If you yourself don't believe what I'm telling you, if you yourself, like Alex saying, being blue in the face, Alex, keep being blue in the face and telling them obesity is a chronic, progressive, recurring disease, because that's been my experience. And that is the experience of many people. And that is costing the healthcare system so much money. So when I think about the experiences, I think of like friends, family, I think of marriage, I think of life, what that was like across the 45 years I can remember, because my first memory is 4 years old. And I was eating a Brussels sprout, which is the most god-awful thing. We call them fart bombs in Ireland because they affect your digestive system so bad that you end up with horrific wind. But apparently they're great for you, and my father loved them. I think of trying to get a mortgage. Something so simple, trying to get a mortgage for my husband, not realizing I had a chronic disease, and fighting and fighting and fighting to prove that my weight wasn't purely only my own fault, that I'd done the soup diet and the cabbage diet, another one that makes you expressively whinge yourself around the world, that I had challenged every diet. I'd done the no eating diet. Don't eat until you almost pass out. How healthy is that? I think of the Action IO study that was done a number of years ago that shows the average person waits 6 to 9 years to seek treatment for obesity. Why is that? I'll tell you why. My very first appointment for getting up in the morning to go to my doctor came after a horrific experience of my son, who's 2 years old, getting out of the car, and my electric gates hadn't closed, And we lived on a road where cars, 60,000 cars a day, were passing at 120 kilometers an hour. They were only supposed to go 80, but it's Ireland, back roads. And essentially, his little legs took off because he seen a bunny the other side of the road. And my body could not take me fast enough to get to him. And I got him about a foot from the road. And I lay on the ground and I cried my heart out at about 140, 150 kilos, thinking, I have to do something about this. I got up the morning of my appointment. Before I turned over in the bed, I was worried I was going to pull a muscle in my back because of the weight on my stomach. By the time I got to the shower, I'd already thought of the underwear that would make me look slimmer. So I was more visually acceptable to my doctor. I thought about the fact that I wasn't going to eat and I hadn't eaten in 24 hours in the hope that I was at least half a pound lighter on the scale. I took off the shower door because I didn't fit into the shower. And I lifted up the folds of skin to soothe them and bathe them so I did not smell. And by the time I get out of the shower and I looked in the mirror, I'd completely talked myself out of that appointment because everything the media said over the years, and all of those words were in my head. You're not good enough. You're lazy. This is your fault. You've done it. You haven't done enough. You should have listened to people. You should have stopped eating. You should have, you should have, you should have. You're not, you're not, you're not. And I didn't go to my appointment. So the Action IO data is very, very real. And that was my experience of it. I think about the self-internalized stigma and how that manifested. You know, I think, like, let's be honest, we all have biases. We all have that little bit of stigma in ourselves. We all have that little bit of doubt in ourselves. We all blame ourselves for, I didn't do a good enough job on that. Or I should have done that better, right? We all say that. I was in school, 9 years old, and it was 9:15 on Thursday morning. And it was every Thursday morning was physical activity class, PE, physical education. And even though I could run fast, oddly, my very little legs could run fast and take my belly to places that I didn't think I could go. Essentially, I was always picked last for the team. And I stood there waiting and hoping that somebody would pick me. And I can actually even remember the marks on the tiles of that floor and the smell of that hall, because I felt leaving that hall every single Thursday morning, I'm not good enough. I'm not accepted by my peers. That was a part of the beginning of self-internalized stigma. I think of how family members thought I was gluttonous because I would have chocolate to self-medicate. I grew up in the back arse of nowhere in Dublin. It's like the Bronx of New York. My father was a chronic alcoholic and woman beater. I was sexually abused. Life was absolutely tremendously horrific and so unbelievably upside down growing up as a child. And I self-medicated when I could with a piece of chocolate. And we had no money, so it's not like chocolate was freely available. But even having that piece of chocolate, I was taught I was gluttonous. That's not good enough. I was the girl who met her first love at 17 years old, and I could not believe that a man seen beyond my body looked at my face and thought I was the one for him. And I married him. I was a girl who was also pregnant and married at 22, very typical Irish Catholic. You settle down, you buy a country cottage down by the sheep and the cows, and you get married, and off you go and have babies as a young woman. I did all of that. I had such a horrific experience in midwife, my first son, because I had gestational diabetes, and everything else said, well, you know what? It's your fault your son is 10 pounds and 8 ounces. My second son, it's your fault your son is 10 pounds 9 ounces. And I had the same midwife, and she was such a lovely lady that I could never challenge her. I had a Rouen in 2005. 18 months later, I had my daughter. Oh, she's 11 pound and 3 ounces. And I said to the midwife, I said, what's going on? She went, I don't know. All of those years of blaming myself for the weight of my child? Not good enough. I'm just out of time, but what I wanted to say was that those experiences led me, in my mind, to think I was all of those words I've said. And I'm going to say it again, that I was not good enough. I was lazy. I was not accepted. I was sloppy. I should have done better. My career guidance teacher, 15 years old, told me, Vicky, go and get a job in the local factory because academia and a career or college is not really for you. So I started off as a glass blower and steel and sheet metal worker. That was my very first job. Believing what she told me because of how she looked at me. Because I visually was not acceptable. I didn't have a triple XL school uniform in the 80s. I had a large and I was bursting buttons every single day and they were so sewn over from my grandmother. It was shocking. So really I wanted to say, Anna, first of all, thank you so much for being so articulate. And when you say about post-weight stigma, that exists. That is so real. And then the yo-yo, the weight regain. Have her own why, gain some weight back. Oh, it's your fault, she's at it again. She's eating too much, she's not doing good enough. And in my head I'm going, oh my gosh, what's happening? I'm gaining weight, and how can I be gaining weight? I can only eat tiny portions. What is happening? Psychologically, that is a mind melt that Mr. Spock couldn't figure out. It is absolutely horrific to go through that. Alex, people say that you're difficult to work with because sometimes you can be, and they were your words, not mine, but I agree, because you don't give up, right? And because you don't give up, I have been disowned by some professors in the community who are here presenting, who said that I am too difficult. And I'm too difficult because we have genetic obesity in my family, and I will not allow this to continue to happen for my grandchildren and for my great-grandchildren, because what the world that we live in is not good enough for them. So I will continue to be difficult, and I challenge you all to be difficult. And I challenge you all to think of that loved one that you have, that person that you know, and every time you think about how you would like them to be treated, what's the answer? You want them treated with love, care, empathy, dignity, respect. You want a shared treatment plan. You want to make sure that they have that for the life course. That is what you would want for your loved one. And that is why we as patients become difficult, sometimes a bit outspoken, and won't give up and are here today. So thank you very much.
Well, thank you so much for sharing, so much personal details and that perspective that we so often lack in clinical practice. So is there any question from the audience? Andreas, please.
My name is Andreas. I'm a bariatric surgeon from Switzerland, and I would like to thank you for that very intimate story of the burden of a lifelong story. Thank you for that. I have a question. Do you have an advice for us healthcare professionals to avoid this skipping of first-time appointments in our outpatient clinics? I mean, as far as I remember, you just told us the story. You skipped your first appointment after preparing for hours and thinking a lot of things, which did not help you to go to this appointment at the end. Is the step for this first appointment so high for you, or do you have an advice how we can lower that?
Thank you. I really appreciate that. I've lots of advice on it. um, essentially, I mean, every single one of us is a patient here, right? At some point, we've all been to a doctor and a nurse. And every one of us as human beings have that same feeling when we go into the clinic. It's, oh my gosh, it's my doctor, what's he going to tell me? Have I, and the question, and I know it's very kind of stigmatizing towards Irish people, the question, how much alcohol did you drink this week? And it's like, if they say 2, it means that's 8, right? And I think as doctors, people hold you in such high regard, almost godly figures, which I absolutely despise, because to me, you're all human beings doing an immense job to change lives. And what I don't see enough of is the surgical community aligning with the patient community and that of the researchers and our clinical community in talking about stigma, in actually being a part of movements, of campaigns. We don't see that. And when it comes to patient support groups, I'm a member of over 1,000 patient support groups across Facebook. And believe me, there's tens and tens of thousands. And they all say the same thing when it comes to the surgeons. They just want to cut. Sorry. That's true. That's what they say. They don't see us as human beings. They see us as, a treatment. And that is because they're actually not seeing the human side of you. They're seeing the incredible skills that you have and the talent that you have, but they're not seeing the fact that you yourself are standing here on a Thursday morning in Malaga asking that question, how can you be more present in the life of a patient, more or less, to stop them skipping an appointment? And I think prime opportunities like Munich in Germany next year, where ECO and IFSO have aligned for the Congress, is a prime space for you to, and I would challenge you to come and join ECPO and put your face to campaigns around stigma as bariatric surgeons, because very, very few of them do. Thank you.
Thank you again, Anna. Vicky, thank you very much.
You're very welcome. Thank you.
Our next speaker is Ronald Liam, who will talk about heroes and villains, the paradox of stigma in the bariatric surgery. Ronald comes from The Hague, Netherlands. He is the chief of surgery, head of his department, and runs one of the largest bariatric clinics in the Netherlands. Welcome.
Well, good morning, everyone, and thank you for the kind invitation. As the last speaker of the session, I might echo some of what has already been said today. But repetition is where the message starts to stick, I would say. Today I want to take you into a problem that bariatric surgery has not yet solved, and that we cannot solve in the operating room, the stigma paradox. My patients can lose dramatic amounts of weight, regain their metabolic health, and yet many of them tell me, sometimes many years after surgery, that they still feel judged. That mismatch is what this talk is all about, and that we as a field, we have to do something about it. Well, my biggest disclosure actually is I'm not an expert on stigma as a surgeon, but I've done some research preparing this talk. So we have 3 goals for the next 15 minutes. First, I want to leave you with a clear definition of the stigma paradox. What is it? Why it persists even after metabolic successful operations. Second, I want to map for you where stigma enters our pathway, not only at the patient level, but also at the public and the system level. And third, I want to hand you some practical evidence, aligned playbook that you can do tomorrow already in your clinic. We start with the paradox itself. Then we walk the pathway before and after surgery and across the system. We examine the mechanisms, why this matters for outcomes, and what we can act on. So here's the central tension. Bariatric surgery is by every modern medical standard a legitimate treatment. We have decades of randomized data, we have the 2020 Joint International Consensus Statement, the updated IFSO ACMBS statements, and yet socially, surgery remains moralized. It is read as a shortcut, as cheating, as evidence of weakness, which means a patient can do everything right, lose the weight, restore metabolic health, follow up perfectly, and still carry stigma or even acquire new stigma after surgery. That gap between medical legitimacy and social morality is the paradox. Everything else in this talk follows from it. To work on stigma, we first need to be precise about what we mean. The health stigma and discrimination framework, which Garcia and colleagues use in their scoping review, distinguishes 4 forms. It has been discussed already. We have the perceived stigma, patients anticipating negative judgments even before anything is said. We have the experienced stigma, the actual discrimination in the clinic, in society. We have the anticipated stigma as the expectation of future rejection. And we have the internalized stigma, which Vicky already talked about intensively. So before the operating room, our patients already carry double stigma. They're stigmatized for living with obesity and then stigmatized again for the treatment they have chosen. Disclosure becomes a calculated risk. Patients delay care, hide their decision from family, sometimes even seek treatment abroad to avoid being seen. The dominant cultural script that surgery is the easy way out quietly shifts the morale frame from disease to character. The patient is no longer someone with a chronic illness seeking evidence-based therapy, but someone taking a shortcut. And this is not just a public phenomenon. Provider bias delays referral and narrows the counseling we offer. The preoperative period is therefore not a neutral stretch of waiting time. It is where many of the downstream problems are seated. So let me anchor this point before we move on. Stigma is not a side issue, not a soft topic, not a chapter to get to after surgical content. It shapes access, disclosure, and readiness long before the scalpel touches skin. So now let us zoom a little bit to the public level. Public stigma towards obesity remains stubbornly high in Europe. That's not new. What is interesting, in the cross-national survey work from the Netherlands, France, and the UK, again by Garcia, is the split. The public increasingly expresses empathy for patients with obesity as people, but at the same time questions whether they deserve surgery. Attitudes vary across cultures, but the cluster around narratives of personal responsibility, the idea that medical help should be earned. Patients live this split daily. They are pitied and judged at the same breath, sometimes by the same person as they describe it as inconsistent and exhausting. What you actually see in those public conversations are 2 competing frames. In the moral frame, obesity is personal failure and surgery is a shortcut. Weight regain is non-compliance and success is read as earned thinness. Only valid if it looks like it came from willpower. In the medical frame, obesity is a chronic relapsing disease. Surgery is evidence-based therapy, regain is relapse risk. The way we would describe relapse in any chronic condition, and success is health, function, and quality of life, not a number on a scale. These 2 frames are constantly colliding in the public mind, in patients' families, and yes, sometimes in our own clinics, and it's our task, and this is a central clinical task of this talk, is to keep the entire pathway consistently in the medical frame. After surgery, stigma does not disappear. It changes shape. The good news is that experienced weight stigma can decrease meaningfully after metabolic and bariatric surgery, and that change in stigma, perhaps more than with the weight loss itself, predicts improvement in mental health and dysregulated eating. But the trajectory is not uniformly positive. For a substantial subgroup, stigma persists, and weight bias internalization contributes to weight regain, creating a particularly cruel loop that Himmelstein and his colleagues have described. Patients regain some weight, feel ashamed, avoid follow-up, and the very system that could help them becomes the place they cannot face. We are losing patients to shame, not to surgical failure. And we now have data going beyond 5 years, 10 years, post-operatively. Body image and stigma struggles can persist. Coping style matters. Adaptive strategies, cognitive reappraisal, assertiveness, outperform avoidance and rumination, but those skills are not innate. They need to be supported. Patients describe living with both hypervisibility, being looked at different because they used to be larger, and invisibility because their history is now hidden. Normally for them, it's not a BMI target. It is a social and physiological reconstruction that takes years. Weight can change fast, but stigma changes slowly. If our follow-up only targets metabolism, we are working on half the patient. Post-operative support has to address metabolism and meaning. Now the part that requires honesty about ourselves. Healthcare is not a neutral observer here. We are part of the problem. Roughly half of bariatric candidates report feeling judged by a healthcare professional in the past years. Provider bias narrows the counseling we offer and the trust patients give us. Primary care often feels underprepared for post-MBS follow-up, and fragmented handoffs between bariatric centers and the primary care amplify rather than absorb stigma. Patients summarize it bluntly. Stigma in clinic is experienced as blame, not as support. If you can take one thing from this slide, take this. We cannot demand that society destigmatize our patients while our own waiting rooms, our own language, and our own follow-up systems still signal judgment. Why does this matter for outcomes? Because there is a clean, repeatable mechanism captured well in Tomiyama's cobwebs model. Stigma exposure is a chronic stressor that produces shame and avoidance. Shame and avoidance reduce follow-up engagement and social support. Reproduced follow-up correlates with dysregulated eating and lower physical activity. Those behaviors drive weight regain, which in turn re-expose the patients to stigma. The loop closes. And here's the key insight from the recent literature. This loop operates independently of surgical quality. You can do a textbook sleeve or bypass and still lose the patient to this cycle if no one intervenes on the social side. So, what can we do about it tomorrow? We can offer a simple framework. You can call it the care approach. Call it a disease, ask for permission, respect the autonomy of our patients, and equip. End every consult with a clear plan and a safe, non-judgmental follow-up route. And the language shifts that go with this are simple. Use proper language, as said already yesterday by Gerhard Prager. We talk about persons with obesity, higher weight, and we try to avoid being non-compliant or failed diet, and especially morbidly obese, which patients consistently report as one of the most painful phrases they hear from us. So care is what each of us can do in a single consult, but durable changes require system-level work. We have 4 levers for this. We have to design a good pathway, seamlessly shared care between primary care and our secondary surgical teams. We have to define the responsibility so that no patient falls into the gap between us. Second, we have to empower the team. We have to routine bias training and importantly standardized non-stigmatized communication so that the experience does not depend on which professional the patient happens to encounter. And third, measurement. Track patient-reported experience, as Vicky already said. We have to beware of mental health and follow-up engagements as core outcomes alongside weight and labs. What we do not measure, we do not change. And fourth, our environment. Appropriately sized chairs, blood pressure cuffs, gowns, skills, and a clinic culture that signals respect before anyone says a word. Legitimacy is built by systems, not by slogans. So one quick word about the new players in the field. As Alex already said, GLP-1 based therapies are highly effective, but they are already running into the same easy way out narrative we have lived with for decades in surgery. Stigma migrates between modalities: surgery, medication, lifestyle, and the culture template, the moralization of weight, and the suspicion of medical help turns out to be remarkably portable. The good news for us is that the solution is also stable. Disease framing, respectful care, and equity of access. The work we do on stigma in surgery directly benefits the wider obesity field. So to conclude, the stigma paradox is treatable, not with better slogans or awareness campaigns, but by redesigning the conversations and the care system so that medical legitimacy gradually becomes social legitimacy. When we reduce stigma, the downstream effects are clinically meaningful: better access, better follow-up, better mental health, and ultimately better outcomes. Stigma reduction is not value exercise, it is an outcomes exercise. 3 takeaways for today, I think. 1, stigma is an outcome issue, not a soft issue. Surgery changes biology, stigma changes meaning. And patients need both addressed. Build anti-stigma pathways at both the micro level and the micro level and the macro level. And if we want durable metabolic success for our patients, we have to engineer dignity alongside it. Thank you.
Thank you, Ronald. I think that was very inspiring and really opened our eyes to how we should see ourselves as healthcare workers, not only as individuals, but also extend it to our team that looks after our patients. Any questions? You want a question?
Ronald, you nicely demonstrated that the stigma seems to wander. It starts with the disease itself, then the people affected by the disease, then people, stigmatize themselves, and finally the treatment is stigmatized. Do you think that, the new era of pharmacotherapy also offers a chance for the, whole medical society to address this stigma with a, let's say, broader group than we were able to do before?
I think Alex already put it in a nice frame. We have to medicalize everything. As long as we do these side steps instead of medicalizing obesity as a chronic disease, then we're actually causing stigma by definition. So we have to stay away from that and just treat it as a disease like we treat any other disease. I think that is the key to avoid stigma and to get rid of it.
Thank you. Another question.
I have a question. Sorry, thank you, Ron, for that presentation. That was wonderful. I have a question. What is your insight coming from the surgical community? How do they see the thesis that you're making that stigma is an outcome, a bariatric surgery outcome that they should worry about?
It affects outcome.
It affects outcome.
Yes.
And do you think surgeons are able to do they feel empowered to think about this outcome? Because surgery is such a, how would they feel like they need to take care of it, they need to consider it? Are they open to this idea?
Not sure, actually,
No.
Jimena. I think that's a very difficult question to answer because I'm just one of those surgeons.
Yeah.
It opened my eyes preparing, and also I found Alex talk very inspiring because we have to look at it as a biological treatment to a biological disease. And I think that as surgeons, we tend to try to improve our treatments by maybe over-treating, because we have to face the fact that some people will not, or some patients will not be treated as good as we thought we could treat them. And that is a little bit, you cannot end surgery, but surgery can end itself, because when people have relapse of disease, despite the surgery we had, should we do more operations, or should we do something else, or not do anything at all anymore? So for me, that was also a little bit of an eye-opener.
But do you think, I mean, I know that the surgical world now understands and functions in an interdisciplinary way. So is there a room for surgeons to collaborate with psychologists and other interdisciplinary professionals to help them manage that stigma, because it could affect outcomes? Is that happening, or do you think that's outside of the scope of surgeons?
I run a dedicated clinic, and it's all about the treatment of obesity. So everybody involved is already taken care of we're all on the same page, for that matter. But it is different if you integrate your bariatric surgery into a general surgery practice, because then you're facing all the other challenges as a surgical clinic. So it is a team effort, and people should be aligned as a team. Totally agree.
Comment on what Marco asked about pharmacotherapy and what pharmacotherapy has done. Surgery, and you'll say I'm biased, but surgery would never have been able to change the narrative because of the scale, okay? There's a few people that do very well, but no one listens to them. It's a small number. The reason why pharmacotherapy has really changed the way we do business is because it's scalable to the masses. And now, thousands and millions of people around the world are pushing their healthcare systems to change the way they think, and they demand treatment which to them seems acceptable, right? Because it's low risk. So I think that's the first reason. There is one more reason, and call me cynical. The second reason is because the people who stigmatize before, policymakers, funders, media, they have started taking the drug themselves. Even surgeons that have previously been very difficult to convince are now taking the drug themselves. And after you have got personal, almost emotional experience on what these drugs do, then you click and you understand what these treatments do. And I can tell you at least 30% of the UK Parliament is taking the medication. This is not a joke. So it's interesting that if you experience the benefits and the way that your own body changes, then you get what we have been trying to tell people for decades.
Yeah, great comment.
I can't wait to see what happens if the UK Parliament actually tries to stop the medication. So thank you to all speakers, to you, Ronald, for this great talk, to Alex, to Vicky, and to Anna. I think this is a very important discussion, and it's a good start into the Congress. I certainly learned a lot. You know, we have to take care of our language. We have to challenge simplistic views, maybe, and assumptions even more. But most importantly, I think what I learned today, we have to listen more to patients actually living with the disease and hear what they have to say. So thank you very much. Enjoy the rest of the Congress, and I invite you to go to the main hall where the best European papers are going to be presented in a new format. They're going to be discussed in detail by 3 referees. I think that's going to be very educative. Thank you very much for coming.